Awesome. We were saying before, I feel like I'm getting more Zoom savvy doing these sessions, so it's good for something, even though no one's doing anything I am. Right, share screen, here we go. Share. Awesome. Cool, and now I need to make this big. It's slideshow, isn't it? There we go.
Yeah.
Places for hiding it, right. Right. Can you see that yet, Katie?
It just says loading right now.
Oh, it might just be working itself up.
Is it just that the Google Doc's not opening?
So I've got the PowerPoint up on mine, but it says your screen sharing is paused. And then I press the Zoom share button, but nothing's happening.
Maybe like stop sharing your screen.
Oh, yeah. See that?
Oh, is it?
Oh,
yes. Oh, wait.
No, you can't see that yet, can you?
It says loading, yeah.
Oh, for goodness sake.
Can you like stop sharing your screen and then slideshow and then share your screen and see if that...
Yeah. Sorry, everyone, bear with us.
We just said we were Zoom savvy.
Yeah, I know, I've jinxed it. If anyone has any bright ideas, please put them in the chat. Okay, right, share.
There you go, that's worked.
Oh, amazing. Okay, perfect. Right, on with the show. So if you've got any questions going along, please put them in the chat. Katie and I will both be monitoring it, but I mean, bear with us for some questions. It is recorded and you will get the slides, but in order to get the slides and the recording, you need to fill out a feedback form. The feedback form will be posted at the end. If you do need to leave early, let us know. We can put it on a little bit earlier as well. Yeah, and when you fill out the feedback form, we'll send you the slides and everything. Cool. So if you haven't been to the Thursday 15 session before, what it is it's foundation doctors like me and Katie running teaching sessions for you guys. And what we've done is a PSA series, of which this is the last of, and we're also doing a finals series. So every Thursday there'll be a different F1 teaching you guys about different topics. So I think we had Katie doing neurology last week, and then before that we had me doing respiratory. And this week we've got gastroenterology, abdominal pain. So that's definitely worth checking out if it's something you're interested in seeing. It's really good to learn about. There's lots of exam questions, and I think it's Holly doing it, and she's really good. So you'll learn a lot. Cool. So how we do it is multiple timed questions, which you guys do in exam format, and then we go through them all and sort of try and simulate your exams and make it as real as possible. The questions we use are stuff that we found difficult. So if you do find them hard, don't worry about it. You're like here to learn, and we'll just go through the answers.
So just if you've been to these sessions before, you'll have seen this slide already, but just to quickly go over the exam format. So there's 8 sections to the exam and it lasts 2 hours. The hardest part about it is the time. So that's why we do these sessions where you go through the questions first under the timings that we suggest, just because we think it's really useful to get a better idea of how it will feel when you're really in there. You get access to the BNF, so you can use the online BNF, and you can also take in your own paper copy if you want to. Some medical schools supply them and some people can get them from their local pharmacy, so look into that if you think that's something you'd want to do. Because it's an online exam, it's really useful that if you don't know it, you don't have to waste your precious time searching and trying to think about it. You can flag a question that you haven't answered or that you've guessed to go back to you later. So don't spend more time than you are allocating on one question. If you've got to your time limit, just flag it and come back to it at the end. Especially the sections that we'll be covering today, they're all multiple choice, so they're quite quick. So you end up gaining back some time on the last couple of questions to go back to the trickier ones and the prescribing things. And there's lots of practice papers that I'm sure you've already done on the PSA website, and QuesMed has a lot of good questions and mock papers that you can use as well.
So drug monitoring, which is a section that I'll be doing today, is 8 questions, which are 2 marks each. So this is monitoring the effects of different drugs. So it's a multiple choice question. Me and Kate were saying before, these are questions that are really good to get a lot of marks in. The answers are in the BNF, and it's often quite easy to find. So hopefully this is a section that you'll already know the answers to. But just like look carefully in the BNF, because that is where the answers are, and they're often just one stage answers rather than doing a lot of thinking. So hopefully you can zoom through these ones. Recommended time is 8 minutes. That's a minute per question. That's all we'll be doing for you guys today as well.
Quite similar for the data interpretation one as well. So there's only 6 of these. So it's only 6% of the whole exam. So you get a clinical scenario where you'll interpret whatever data they give you. So it might be a blood test, a nomogram, or whatever, and you decide the most appropriate action. So you might stop a medicine, reduce or increase a medicine, or change a medicine, or say, oh, I won't do anything. They're all SPA style like the last one. And yeah, so minute per question, 6 minutes.
Cool. So let's get straight into it. So I will time you guys, and I'll let you know when we're moving on from a question as well. So you'll have a minute per question. So let's go. If you've got any questions along the way, just pop them in the chat. Next question. 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 Sorry. Okay, that's last question. Yes, to all you people putting in questions saying, is question 8 missed? Yeah. Is there an answer slide in there, Katie?
No, it does say answer at the top, but the answer actually isn't on the slide, so it's safe to go back to question 8.
Okay, everyone, I'm going to go back to question 8. I just wanted to make sure it wasn't an answer. I was texting Katie like, what's going on? Okay, this is question 8, which doesn't have an answer. I'll give you a minute for it now. Go. Cool, right, time is up. Let's skip past the 9 and 10 that we've done already and go to the answers. Okay, so pens down, everyone take a big deep breath and we'll go through now. Again, if you've got any questions at all, please pop it in the chat, and while I'm talking, Kate will try and answer and vice versa. Right, so the first one, drug monitoring. A 35-year-old man has received a new diagnosis of schizophrenia. His GP decides to start him on olanzapine. What is the most appropriate monitoring for science medication? Let's try and get a poll up. Right. Launch. See what you guys think. Cool. Yeah, you guys absolutely smashed it. So the most appropriate monitoring here is, in fact, weight. So just looking at weight comparison to the BNF, in olanzapine here, it says blood lipids and weight should be measured at baseline at 3 months and then yearly. So with olanzapine, you need to measure lipids and weight, and fasting glucose as well. And I think you also need to measure prolactin as well, just as the type of drug class it is. A really good way to do these questions is, I found the BNF online so much easier to use because you can search for things on it. So you can, if you do like Control F, that's like how to search, it's a search key. And you can just type in monitoring or like monitor, and then it'll take you straight to this. So it's really quick and easy to do. Cool, next one. Question 2. A 78-year-old woman is recovering on the ward after a left total hip replacement. She's developed a productive cough with green sputum. Yada yada yada, lives in a nursing home. Those are her medical conditions and medication she takes. So she started on amoxicillin as per trust guidelines. What is the most appropriate way to assess the beneficial effects of this treatment? Cool. Oh, let's see if I can launch this pod again. Cool, there we go. Let's stop it there. So the answer is respiratory rate. You guys are exactly right. So the reason it is respiratory rate is because this patient has a chest infection. So this person has a pneumonia. And you can assess pneumonias in a lot of different ways, but the most appropriate way to monitor a patient is how the patient is, their side effects, and their symptoms. So with the respiratory rate, that is the parameter you're going to be monitoring in a chest infection. So you're going to be monitoring like SATs, respiratory rates, temperature, blood pressure, to see if the patient's getting any better and to see if the treatment's working. So if the antibiotics that you're giving the patient is working, they're going to be better in themselves. So they're going to look better and their observation is going to be better, which is why it's respiratory rate. So CRP and full blood count as well. So CRP and white cells are a measure of infection. So it can tell you if someone has an infection, and it can tell you if the infection is improving, but it's not the best way to monitor if that patient is actually getting better and if that treatment is actually working. So the best way to see that is actually how the patient is. Similarly with chest x-ray, you can obviously see a pneumonia on a chest x-ray, and you can see resolution of that pneumonia with treatment. But again, the most appropriate way to monitor, is this treatment working? Is this patient getting better? So is the observations improving? Amoxicillin, you don't actually need to monitor blood levels for as well. So that's a bit of a red herring. Cool. Next question. Katie, let me know if there's any questions that are coming through that you're not sure about. So next, so 22-year-old's been reviewed after admission to a psychiatric ward. He has sort of all these manic symptoms. His flatmates are concerned he's not acting himself. He started on lithium. So what is the most appropriate parameter to monitor in lithium? Let's see what you guys think. So the answer is thyroid function test and use knees. Yeah, you guys got this exactly right. So again, this is another one where you scroll to the drug monitoring section of lithium page on the BNF, and right down at the bottom it says monitoring of patient parameters. So importantly with lithium, you also monitor the serum lithium concentration. You do this at frequent intervals when starting treatment and all the way through treatment. But that wasn't an option I gave you guys. So yeah, the correct answer was using these and thyroid function. And in that paragraph there, you can see it advises to assess renal, cardiac and thyroid treatment before treatment initiation, and then also electrolytes, EGFR and thyroid function every 6 months. So that's exactly right. Remember that you won't be searching for TFT in the BNF. So if you want to see TFT, you need to type in thyroid. Using these, you need to type in electrolytes. Just it is a little bit different than it is that you think about it in your head. So remember that. Cool. Question 4. An 89-year-old man is in a urology clinic. He's been having recurrent UTIs and is awaiting a TIP. He starts them on nitrofurantoin. Which test is the best to monitor for the negative effects of this treatment? Have a look. What you guys thought? So we got, yeah, exactly right. So this is a question all about adverse effects of treatments. And nitrofurantoin, a really important side effect of long-term treatment is pulmonary fibrosis. And this is a quite often asked exam question, so it's really good that you guys are picking this up here as well. Pulmonary fibrosis, obviously, you can see on a chest x-ray. You won't see it in urine MCNS, and you won't see it. You can see raised CRP and pulmonary fibrosis if you have an infection on top of that, sort of exacerbating your pulmonary fibrosis, but it's not a good test to monitor for fibrosis in itself. Chest x-ray is much better. Sputum culture, again, would only be positive if you have a superadded infection on top of your fibrosis. Fibrosis does make you more susceptible to chest infections, but it isn't a good way to look for it in itself. And then blood pressure isn't relevant. Cool, and just looking at where you find that in the BNF. So the first place you can find that as well is in monitoring of patient parameters, which is the section you should be looking in for all these questions. The BNF has like a monitoring section for every drug that requires monitoring. So on long-term therapy, monitor liver function and monitor for pulmonary symptoms. So that's referring to the fibrosis, and then you can find that in the side effects, where it says acute pulmonary reactions usually occur in first-degree treatment and chronic can develop insidiously. So discontinue that case. Cool. Just kind of a quick look at the questions.
So there've been quite a few asking just about respiratory rate being the answer to question 2, that I've been kind of fielding, and I think it would be useful to kind of just say say to everybody why that was the correct answer, just
Yeah,
to
we'll just go back to that. What was it? This one? No.
the one before that.
Yeah. So clinically, when you're in a hospital and you've got someone who's got a chest infection, they're coughing up loads of green mucky stuff, they're really short of breath, they're really, really, really fast, and you start them on amoxicillin. So there are a lot of ways to assess if an antibiotic is having an effect. However, the best way to assess is your treatment working and is your patient getting better is clinically, is your patient that is sitting in front of you getting better? Are they still breathing really quickly? Do they still have a raised temperature? Are they still coughing up loads of horrible green phlegm? Which is why that is the answer. These questions, the reason I put a question like this is because in my PSA, that question tripped me out. I thought, oh, it needs to be an imaging, but actually, like, fundamentally, the way you treat people is by seeing, are they getting better? Which is why it's respiratory rate. So if you see a question like this in your PSA, like, just think about, how am I actually going to tell this patient sitting in front of me is better? Like, is it more important that their chest x-ray is resolved, or is it more important that their observations, their respiratory rates come down? Because you can have a patient that is really, their chest infections really improved, but their chest x-ray still looks horrible. But you can have a patient whose chest x-ray isn't that bad, but clinically they're a lot worse, and they are the one that would need antibiotics compared to the other patient. Blood tests and chest x-ray are still really important, but we use those as like an add-on, don't we? We use those to confirm our diagnosis. We use those to confirm whether the patient's getting better. And the actual best way is looking at the patient and seeing if they're getting better. I hope that clarifies things for you. Hopefully
I've also just said that these MCQs are also single best answer questions. So don't get fixated on like they're all correct, because a lot of them will be correct, but it's asking you like which is the most correct answer out of these 5 things. So we've gone through the reasons why respiratory rate would be the most sensitive measure for this, but it's not to say that we wouldn't use those other things alongside it in clinical practice. But in this question, it's like which is the best way.
Yeah, absolutely. So in clinical practice, you probably actually use all of these, apart from obviously amoxicillin blood levels. But the questions that you will find hard are the questions where, some of them are right as well, but it's like, which one is the most right? And I think in your finals, those are the questions you'll find the hardest as well, because you're sort of like, oh, like, which one is like, which one's the most right of all the right? And in this one, it is respiratory rate. And do you need a follow-up chest x-ray after 6 weeks in pneumonia? Yeah, a lot of consultants do like having a follow-up chest x-ray just to check for resolution of symptoms, but again, it's not the most appropriate monitoring in this sort of like acute setting.
The reason why you would request one at 6 to 8 weeks is because I think a lot of the time, you want to check that any consolidation you saw has resolved after 6 to 8 weeks and there's not any kind of like background changes, and you want to make sure that consolidation wasn't shadowing anything that you couldn't see initially on the chest x-ray. So that's why you only really do chest x-rays at 6 to 8 weeks for patients who had chest x-ray findings in their acute presentation. So someone can have a pneumonia but have a relatively kind of clear chest x-ray. It's not always that sensitive for picking it up. So you probably wouldn't repeat their chest x-ray at 6 to 8 weeks because it was clear the whole time. But you would repeat someone who had like really dense right lower zone consolidation to make sure that they didn't have anything behind that you would want to like CT to rule out malignancy or something like that. Yeah. So that's just
there's a question saying, what about if sputum culture is also an option in the answers? So sputum culture isn't a very good way of seeing if an infection is resolving. So you can see, do they still have bugs in their sputum? Do they not have bugs in their sputum? Has it completely resolved? But it's not a great way to assess if your treatment is working, because it often takes a while for those bugs to go. So the patient could be a lot better and you can still have a positive sputum culture. But sputum culture, I mean, it could have been another one of those right answers, but not the most right, because it is still an important test for chest infection. Hopefully that answers that question. Is CRP not a good way of assessing improvement? Hopefully you've answered that. It's something that you would use, but again, think about it. You're a doctor, a patient sitting in front of you. Are they getting any better? Are they getting any worse? Is the management that I'm giving them working, or do they still have a new score of 7? Because if they do, your management isn't working. Cool. Do you feel we've answered that, Katie? Happy to move on?
Yeah, I think so, yeah.
Cool. Any more clarification, just please pop it in the chat and we can always come back to it at the end. What did we get to?
Did you get to question 4?
Yeah. Oh, yeah. I'm glad I've got you to keep me right. And we answered this one, didn't we? Cool.
Yeah.
Question 5. An 18-year-old man presents to the neurology clinic after having his first seizure. The neurologist starts him on lamotrigine. What is the most appropriate monitoring option during the first 6 weeks of this treatment? Let's get another poll up. Smashing the polls.
Just to say, try not to raise your hands because we can't let you talk. If you have a question, just pop it in the Q&A. Is that okay?
Cool. Let's see how you did. Yeah, exactly right. None of you fell for my trick. So this lamotrigine is a drug that doesn't require any monitoring at all. And the reason I put this question in is it's okay to not do anything in the PSA. So there are a lot of PSA questions where they're all asking you about what you would do as an F1. And sometimes the answer is do nothing. Sometimes the answer is, your treatment's working, everything's fine, leave it as it is. And sometimes it is actually not all drugs need monitoring. So lamotrigine requires no routine monitoring apart from in pregnancy. So plasma drug concentration should be monitored before, during, after pregnancy. And this patient wasn't pregnant. Cool, that's okay. Before we move on to Katie's section, I'll just have a look at the questions. On these questions, the answers tend to be OBS clinical signs. Hopefully we've answered this. So if it's an appropriate way to assess whether your treatment is working, think about observations and how the patient is clinically. I would say that these questions, in my experience, did lead you towards a clinical measure rather than a biochemical measure. I think what it's getting you to think about is the patient, and rather than the investigations you're seeing. Like, you'll have heard all the time on the ward, but what we do is we treat the patient, we don't treat the results. So I found when I was in the PSA, those questions do lead you down that path. But just because I've said that, don't take that as law. There will be some questions that are phrased a little bit differently that require some sort of monitoring, but it's just about using sort of your common sense and your clinical practice, and going from there. But think about observations.
Just following on from that, with the question 2 wouldn't require the use of the BNF. So you do have like all your clinical knowledge from finals that is all relevant to the PSA. So don't get hung up on the fact that you have the BNF and think that you have to check absolutely everything because you'll know the answer to a lot of them already. It will waste your time if you BNF everything. It's kind of there for you to double check your prescribing, which is what you should do in safe practice anyway, to make sure that you've got the right dose and frequency of the medication. But you don't have to use it for every single question. It's obviously there as a resource, so use it if you need it. But some questions, the answer won't be in it, and you'll know it yourself. Well phrased. What does pulmonary fibrosis from nitric tone look like on a chest X-ray? That's a really good question, and I did do a respiratory session last week, and I can't remember. So pulmonary fibrosis generally looks like it's sort of all over the lung or the lobe. So where consolidation might just be a patch, fibrosis is a lot more widespread. It sort of just looks like fine white lines a lot of the time, and sort of like groups of fine white lines. You'll see that it looks different to another part of the lung, so it looks a bit more white than black. It's the best way I can describe it, really. Yeah, it's often described as like ground glass on a CT scan, and you can describe it like that from a chest X-ray as well.
Someone wants the link in the chat, so I'm just going to pop that in if you need to head off early. I'll put that in the chat as well. How can I see the previous lecture slash slides? This is one of our most common questions we get asked. I'm really sorry, but unless you were at this session, there's no way to access the slides recording. So like myself and Katie, it's sessions run by F1s for free. So to protect people's work and data, we need to have feedback forms to send it out to people. So hopefully you guys can understand that. That's how we run it. I'll pop the link in the chat if anyone needs to leave early. Cool. Got it? Yeah, cool. Go on, Katie.
So we're going on to the data interpretation questions now. So this was the first one. So we'll set up a quick, is it okay if you do a poll for it?
Oh yeah, of course. Oh yeah, sorry, I forgot I'm in charge still.
Right, sorry. So this question was about an 84-year-old lady who's been in hospital 3 months, and now she's got a new oxygen requirement. We know that she's got background COPD, and we've shown you her chest x-ray there. So what is the right thing to give her? So you've all gone for, well, most of you have gone for D and C, which is good. So the correct answer, if we just pop onto the next slide, is D, which is tazocin, an antibiotic called tazocin. So the reason that that's the correct answer, let's just go through all of them. So if we look quickly at the stem, so she's got an oxygen requirement, she's got a temperature, she's a little bit tachycardic, and she's on some oxygen. And just looking at the chest x-ray there, you can see that she's got some right lower zone consolidation, just a little bit of like patchy opacification in the right lower zone. So A, frusemide. So her oxygen requirement could be because of fluid overload, given that she has got a history of heart failure. The chest x-ray itself doesn't look overloaded. It doesn't look like it's got that classic kind of pulmonary edema batwing appearance. She's got no new pleural effusions, and she's got a temperature, so it wouldn't explain her being febrile. So IV amoxicillin, that's the treatment for a community-acquired pneumonia, and this lady's been in hospital for 3 months. So this would classify as a HAP rather than a CAP. So if you develop symptoms of a pneumonia after being in hospital for more than 48 hours, then it's hospital-acquired, not community-acquired. So 3 is oral doxy and oral pred, which is the treatment for an infective exacerbation of COPD. And you might very well give prednisolone alongside tazocin, given her history of COPD, but this option isn't given, and it's not clear if the HAP itself is what's causing the exacerbation for COPD. So we need to treat that essentially with some antibiotics, and doxycycline isn't one that you would use for a HAP. So tazocin's the right answer as per the BNF guidelines, which we'll go through in a second, and nebulizers wouldn't be appropriate to treat a HAP because it's not an antimicrobial and there's no history of a wheeze, so it wouldn't be the definitive treatment for her. So just going on to the next slide, the treatment summary that you want is called respiratory system infections antibacterial therapy, which covers lots of different respiratory infections. So I think it goes through epiglottitis, bronchiectasis, COPD exacerbation, CAP, HAP, and an acute cough. So if you're looking for any information on any of those when you're doing the PSA, it's under respiratory system infections, if you're struggling to find it. So the reason it's a HAP is obviously because she's developed these symptoms 48 hours or more after hospital admission. It's important to distinguish between these two things because they've got completely different antibiotic guidelines because they're caused by completely different bugs. So CAPs are normally caused by like strep pneumoniae, but HAPs, if they're early onset, then they would probably be caused by the same thing as a CAP. But if they're late onset, then they're caused by things like Pseudomonas and MRSA, which are resistant to a lot more antibiotics and things like amoxicillin. That would be the standard treatment for a pneumonia. So you give them tazocin, which might seem quite extreme, but actually HAPs have a really terrible prognosis. I think it's something like 30 to 70% mortality if you get a HAP in hospital, and it will increase your hospital stay by like a week or longer. So they take it really seriously and give tazocin. So the reason this was a data interpretation question was because obviously you had a chest x-ray and you had to interpret her OBS to come up with the correct diagnosis. Another thing to mention is that it's important to remember that the antibiotics that are suggested in the BNF will be different at different hospital trusts. Hospitals all have their own specific guidelines on what they give for these sorts of infections. So for example, where I work, the guidelines vary based on whether the HAP is an early or a late onset, or whether the antibiotics have been given, whether the patient's had any antibiotics recently. So just in reality, when you're in your hospital working as an F1, you won't necessarily go on what the BNF says, you'll go on what your microbiology department say. But for the purposes of this exam, when you look at this treatment summary, it says IV first line tazocin, so that's the correct answer.
So Katie, just before you move on, so there's a few questions about why it's a severe HAP rather than a mild or moderate HAP. Have you got the guidelines there?
The guidelines.
Sorry, do you want to go back to the previous page?
Yeah. So the reason she's got severe HAP is because she's developed these symptoms after being in hospital for 3 months. So she's more likely to have got a bug that's at a higher risk of resistance than a bug that has a lower risk of resistance, if you see what I mean. So it's a bug that's come from a hospital because she's caught this in hospital. So then you'd give Tazocin. I'm pretty sure on the respiratory system infections BNF thing, it kind of explains why, what is a higher risk and what is a lower risk HAP. But I would double check the guidelines on that. But I think you would call it high risk of resistance if they've been in hospital for a long time. She's also got relevant comorbidities, things like COPD. So you would want to make, and she's old and frail, coming with a fall. So you'd want to give her something pretty hard hitting. I hope that makes sense. So I hope we've answered some of the, I'm just skimming through a couple of these questions. We know it's a HAP because she's developed symptoms of a pneumonia and she's got consolidation on her chest X-ray. So it could be that the HAP is causing an infective exacerbation of her COPD, but underlying that is the fact that she's got a hospital-acquired pneumonia because she's developed a pneumonia after having been in hospital for more than 48 hours. So CURB 65 is used for community-acquired pneumonias, not HAPs. We'll go on to the next question now, and we'll come back to some of these at the end, if that's okay. So this question was about interpreting this person's ECG. So do we have another poll for this one? Is that okay, Alex?
Yeah.
Well done, everyone. You've all smashed this one. So most of you have gone for A, which is the correct answer. So the answer to this is verapamil. So hopefully you all identified the ECG was showing a second degree heart block. So we'll just go through these answers and then we'll have another look at the ECG. So A, verapamil, it's a rate limiting calcium channel blocker. So that's contraindicated in high grade heart blocks, which is why you can't give it for this patient. Ramipril is an ACE inhibitor that you give for hypertension and it doesn't impact conduction in the heart. Ranolazine is an anti-anginal add-on medication that isn't contraindicated in heart block. The manufacturers advise caution in long QTc intervals, and heart block can prolong your QT, so it would be important to check that. But but verapamil's more correct because it's an absolute contraindication to having that drug. Nifedipine, so that's also a calcium channel blocker, but it's not rate limiting, so it's not contraindicated in heart block. And bentrafluomycin is a diuretic, which wouldn't impact conduction in your heart. So just to quickly go through the ECG itself on the next slide, if that's okay. So it's second degree heart block, and then it's Mobitz type 2. So in first degree heart block, you have a prolonged PR interval, but you don't miss any beats. And then in second degree heart block, you end up having intermittent non-conductive P waves, so you do miss beats. So Mobitz type 1 is Wenckebach, so it's when your PR interval gets longer and longer and longer gradually, and then eventually you drop a beat. Whereas in this ECG, we can see that the PR interval is pretty static, and the P waves are coming at a pretty constant rate. But there's intermittent non-conductive P waves. So you can get it where you get like 2-to-1 blocks or 3-to-1 blocks. And medications that would be contraindicated in a high grade block, like second degree or above, would be rate limiting calcium channel blockers like diltiazem and verapamil, beta blockers, digoxin and amiodarone. So the reason it's kind of higher grade, so Mobitz type 2 is thought to be kind of more serious than Mobitz type 1, is because it's kind of more related to structural damage of the conduction system, whereas Mobitz type 1 is more just suppression of the AV node. So Mobitz type 2 is more likely to progress to complete heart block than Mobitz type 1. So just to go through the different types of calcium channel blockers really quickly, because this is something that always confused me when I was a medical student and kind of now. Verapamil and diltiazem are the non-dihydropyridine calcium channel blockers. So those two are more selective for the heart. And then nifedipine and amlodipine are the dihydropyridine calcium channel blockers, and they're some more selected for your blood vessels. So the diltiazem and verapamil are the ones that you can use for people with arrhythmias and rate control problems. And then the other two are generally used to treat things like hypertension and angina. Yeah, so that's the answer to that question. So the next one was all about patients' insulin. So we've got a type 2 diabetic who is on a basal bolus regime. So they take 38 units in the morning and 14 units at night. And then they have some Novorapid before their meals. And the nurse has asked you to have a look at her blood sugars because she's a bit worried. So if we look at them all together, you can see that at 6 a.m. in the morning, she's having some hypos, so some BMs that are less than 4. And then throughout the day, they're fairly static and within range. So you've done really well on this one as well. Most of you have gone for C, which is the right answer. We just go through why that is. So if we go through A, so sorry, can we just go back one slide, please? So A, omitting the morning Lantus would be wrong because you shouldn't really omit people's long-acting insulins unless you're acting on kind of specialist advice. B, so the morning long-acting insulins would affect her evening BMs. C is the right answer because we're reducing her evening insulin. D, so stopping the evening meal Novorapid, because it's a rapid-acting insulin, it wouldn't affect her morning BMs. And then E, no changes. Well, the patient's having morning hypos, and that's obviously unpleasant and potentially dangerous. So we need to do something about it. So that's why C is the right answer. So just in terms of questions like these that are asking about insulin interpretation, on the next slide, if that's okay, Alex. Thanks. You have to look at trends in the blood sugars. So don't act on like a single spurious result. And when you're adjusting people's basal insulin doses, then the culprit for the hypo will be the dose before. So it won't be her morning insulin because she hasn't had it yet that's making her hypo. It'll be the one that she had before she went to bed. And you tend to adjust insulin doses by about 10%. So you don't make big changes. You just make a small change and then have a look at the result before you kind of do anything else. Yeah, so I've kind of made a bit of a table to try and help. It's very, very simplified. So obviously use your clinical knowledge as well. But just to clarify, a bolus is the short acting that you get prior to the meals, and the basal is the long acting that you take once or twice a day. So if the early morning glucose is low, then you should decrease the evening basal dose. And if the early morning glucose is high, then you might need to think about increasing the evening basal dose because that's what's going to affect her morning glucose. And then if they've got very low or very high lunchtime glucose, then you might want to think about adjusting the breakfast bolus dose. And if the bedtime glucose is low or high, then you could have a look at the morning basal or the dinner time bolus doses. So hopefully that's a helpful summary for you. And if you fill in the feedback and get the slides, there's a couple of links that I've put in the notes section to kind of good information and things that helped clarify it for me when I was starting to work.
Sorry to answer some of the questions.
No worries. This insulin table isn't in the BNF, I've just made it, but it is something that you have to learn because it's something that you have to do all the time when you're an F1. And they can ask you things about adjusting people's insulin in the PSA. So it's important to know that if they're having early morning hypos, that you adjust their evening insulin and vice versa. So the reduction in this question, more than 10%. So I think I adjusted it by like 2 units. So it's 10 to 20% that you can adjust it by. But I think a general rule of thumb, if they're on quite whacking doses of insulin, is kind of like 2 to 4 units at a time.
There's some questions about target BMs. So what I've always said is you want to have about 4 to 7 before eating and about 8 to 10 after. I don't know what you've seeing Katie, but that's sort of what we target. Obviously someone's glucose is going to be high after they've eaten, that's fine, that's completely normal, but you want to try and keep it below, well, around 10. Yeah, I'd say no higher than 15 would definitely be abnormal.
The targets are a lot slacker when patients are inpatients in hospital than when they're patients in the community. So you tolerate kind of higher blood glucose because you just want to avoid people having hypos when they're unwell.
Cool. Do you want to answer more questions or should we move on? What do you think?
Let's move on and do a couple of them at the end.
Cool.
So this next question was about GENT levels. So a 24-year-old lady has been diagnosed with urosepsis and she's prescribed some gentamicin, and then they've taken a level at 11 hours after starting the last infusion and it's come back at 5.9. So the question's asking you to use the graph basically to say what the best thing to do is next. Okay, well done everyone. Most of you have gone for C, which is the right answer. So give the next dose after 36 hours. So just going through them all, A isn't an appropriate thing to do because there's no indication to give amikacin to this lady. The infection, we haven't been told that the infection's resistant to gentamicin, and it's not like she's not having an adverse effect. It's just that we need to adjust how we're giving it to her. B, so the dosing is calculated based on an individual's weight and renal function, and we don't have her weight or renal function, so we don't have the information to calculate a different dose essentially, and dose adjustments aren't advised based on the graph that you're given to use in this question. So C, based on the nomogram, adjusting the dose to 36-hour intervals is most effective. So I've put on a helpful line there to show you how 5.9 milligrams per litre and 11 hours after the infusion would fall nicely in the 36-hour box. D would obviously be too long an interval, and E isn't appropriate because the dose interval currently is too high or too close together. So she's got an increased risk of toxicity with it. So gentamicin's got a kind of drug with a very narrow therapeutic index. So you want to make sure that the gent level is always within the right range, because otherwise she's at risk of side effects. So just to go on to the next slide, aminoglycosides are often used to treat severe infections. They're quite good at covering gram-negative anaerobes. So you use them if someone's got like a severe sepsis with an unknown source, something like a pyelonephritis or a complicated UTI, biliary or intra-abdominal sepsis, or endocarditis. You often only give them for one dose, like a stat dose of gent, you often hear people say, or you'd give them for a less than 7-day course because you really want to minimize the risk of them getting toxicity from it. Generally, gentamicin is given as a once daily regime unless they've got really poor renal function, and then you'd give them maybe a bit differently. So yeah, narrow therapeutic index essentially just means there's not very much room between the therapeutic dose and the toxic dose. So you want to be monitoring U's and E's daily because it's nephrotoxic, and other signs of toxicity might be somebody who's got reduced urine output, deafness or tinnitus. And as I've said already, so the dose calculation is based on weight and renal function. So you can use, like I always use online if I'm ever going to prescribe someone like a gentamicin dose calculator. And then I just put like someone's age, weight, height, and creatinine into that, and then it comes out with what is the most appropriate dose. And that's mostly what like pharmacists use as well. So it's quite accepted practice to use a gent dose calculator. It's safer. Different guidelines on monitoring drug levels vary between trusts. So some trusts would say take a gent level 6 to 14 hours after they've had their last infusion, and then use that nomogram that we've used in the question to adjust the dosing interval. Other trusts would say take a level at 24 hours after the dose. So that would be a pre-dose or a trough level. And then if it's less than 1 milligram per litre, then it's okay to give the next dose. or if it's more than 1 milligram per litre, then you would adjust the dose interval. But this question, it was obvious that it wanted to use the nomogram because it gave you a level that was taken 11 hours after the infusion, and it gave you the nomogram to use. So if it wanted you to use the pre-dose level, it would make that clear in the question, and it would give you the range that it wanted it to be in. So it would be obvious for you to interpret it. Other things that they could ask you about in terms of drug level monitoring are things like vancomycin, tacrolimus, phenytoin, lithium. They're all things that you sometimes need to monitor the levels of. You don't need to learn exactly how to monitor all of those things. It will either be on the BNF, or they'll give you the information in terms of interpreting the drug level in the question. But it's useful to be aware of. So if you've got the time in your revision to have a quick look at what's normally standard practice with those different things, then that's useful.
Cool. And just look at the question, I think someone missed the answer to that, so let's go back quickly. Question 9. So here's the answer: give the next dose after 36 hours. And that's, I believe that's 36 hours from the first dose, is that right?
Yeah, so like instead of giving her a once daily regime, you'd give her a regime that's a dose every 36 hours.
So it goes from when you gave the gentamicin. So how often should you give gentamicin? Not from when you get the results, because that would make no sense because labs process everything differently. And there's a couple of questions about what happens if it's on the line. I think they'd be really mean to give you a question where it's on the line, but I think with all aspects of medicine, just do whatever's safest. So if it's on the line, I'd probably go for the higher one. And I think you can justify that by saying, gentamicin is very easily given as an overdose. I wouldn't want to overdose this patient.
Yeah, if it's on the line, definitely go for the one above, but I don't think I would do that.
Yeah, and that's just good to keep in mind for all aspects of medicine. I think just go for what's safe if you're not sure. Cool. Moving on, question 10.
Okay, so the last question is about a man who's had a paracetamol overdose. So he thinks he took about 40 tablets over a 45-minute period yesterday. It's now the afternoon, so we know that he's taken this overdose over 24 hours ago. He currently feels nauseous and has some yellowing of his sclera. His abdomen's soft, he's not confused, and we've got some blood tests back as well. So it's just asking you what the best thing to do is next. Okay, well done, everyone. Most of you have gone for B, which is the right answer. So we'll just go through them all now. So A, we've said use the paracetamol overdose nomogram to determine if IV NAC is indicated. So it's a suitable and safe thing to do, but this man is presenting saying he took his overdose yesterday morning and it's now the afternoon. So by kind of logic, we can say that he took his overdose more than 24 hours ago, and after that time period, then the nomogram's not a very reliable tool to use. So the most appropriate thing to do for this man would be to prescribe him NAC straight away. And we'll go through why that is in a second. But just to rule out the other ones, so C, take another paracetamol level after 4 hours. It wouldn't alter the management, and it's just likely to decrease as it eventually gets metabolized by your liver. D, urgent discussion with liver transplant setter. So the patient's results provided don't meet the criteria for a liver transplant, and we can go through what they are in a second as well. And E, admit for 24 hours of observation and refer to liaison psych. So this guy has ingested over like 150 milligrams per kilogram and is showing signs of acute liver injury. So he's got some jaundice, he's got a little bit of a transaminitis, his INR is slightly higher than it should be. So you've got to manage the acute medical issue first. Liaison psych wouldn't see the patient if they were medically unwell still from the paracetamol overdose. So you've got to manage it and give the NAC. So that's why B is the best answer here. So the BNF treatment summary that you're looking for this one is called poisoning emergency treatment, and it's actually a really comprehensive treatment summary. Some of them are quite hit and miss in terms of finding the answer that you're looking for, but this one's actually really, really good. So the patient's presented essentially with an uncertain time frame, but the question suggests that potentially it's more than 24 hours ago. And if you calculate, so he says he took 40 tablets, which would be 20,000 milligrams of paracetamol, and 20,000 divided by 80. I can't do that maths in my head right now, but it's definitely more than 150 milligrams per kilogram that he's ingested. Even if he'd presented less than 24 hours after taking the overdose, that would qualify him for some NAC. You can see there in the BNF screenshot, it says patients who present 8 to 24 hours after ingestion of more than 150 mg per kg of paracetamol, then you would give them acetylcysteine. But if we think he's more than 24 hours over, then it says if they're clearly jaundiced, which this man was, or has hepatic tenderness, which we didn't mention, his ALT was above the upper limit of normal, his INR was greater than 1.3, and his plasma concentration was still detectable. So we would still give him NAC, whether or not it was a bit less than 24 hours or more than 24 hours, he still qualifies for some NAC. So just to talk really quickly about paracetamol overdose, other investigations that you might want to do are things like use NEES, full blood count glucose, a clotting and an INR to look at the synthetic function of the liver. You might want to do an ABG to look for any metabolic acidosis, an ECG and a urine tox screen, and any levels of anything else you think they might have taken if they've said that they've taken a mixed overdose. So if someone presents kind of less than 1 hour after taking the overdose, then you might consider something like activated charcoal, and you'd wait till 4 hours to take the paracetamol level bloods, because that's when the nomogram comes into its own. If it was less than 8 hours, then you would take the bloods at 4 hours still, or straight away if it's been more than 4 hours since they overdosed. And then you'd look at the nomogram and you'd give them NAC if the level was above the treatment line. So then 8 to 24 we've already gone through, and over 24 we've gone through as well. The thing to mention is if this was a staggered overdose, so if this man had taken the paracetamol over a period longer than an hour, then the nomogram doesn't apply either. So you would give NAC if you thought they'd ingested more than just 75 mg per kg. So the threshold's a bit lower for giving NAC in a staggered overdose, and the nomogram doesn't apply. Things about NAC, so common side effects are like that allergic or anaphylactoid reaction. So you might get things like erythema, flushing, itchy skin. If that happened, then you'd stop the infusion, you'd give them a bit of antihistamine and restart it at a slower rate. If there's obviously any anaphylaxis, then you'd treat that as per trust guidelines with adrenaline, and then you'd seek some senior toxicology advice about how do we treat his overdose if we can't give him NAC. Yeah, so that's kind of the answer to this question. I would say as well, just if we go on to the next slide quickly, is that okay? Yeah. The poisoning treatment summary is really, really good. It's well worth having a proper look at and spending some time seeing what kind of information's on there. Just because it covers so many different things. So it covers paracetamol overdose, and within that it has stuff about acetylcysteine doses and administration. So in theory, the PSA could ask you to prescribe the first bag of NAC, and then you'd need to know like what volume was needed and stuff like that. And it has a really handy table in that treatment summary about how much you give based on people's weight and stuff like that. So it's very helpful. It also has a picture of the paracetamol nomogram. So if you think you need to use it and the question doesn't have it, it is in the BNF, but I don't think that they would do that. It has lots of other stuff in there as well. So antidepressant poisoning. So that would be helpful if someone had overdosed on a tricyclic and you wanted to know what to give them. Antipsychotics, benzodiazepines, beta blockers, calcium channel blockers, and then loads of other rogue ones as well. So it's a very helpful treatment summary if you're thinking, why are they asking me this? I've never heard of like organophosphide poisoning. It's all in this treatment summary. Yeah, that's that. Cool.
Cool. Let's go through some of the questions.
Okay.
So this question saying, I don't understand how to work out that he ingested more than 150 milligrams per kilogram of paracetamol, as soon as it says. So the way to work this out is work out how many tablets he took. Practically, this can be very, very difficult, but in your exam question, if they want you to work out what his mgs per kg are, they'll give you the tablets. So a paracetamol tablet is 500 milligrams. So work out how many tablets he took. So he took 2 tablets, that's 1 gram, obviously. And work out his weight if he took more than 150 milligrams per kilogram. So to work out this, you do 150 milligrams times his kilograms, and to get how much he took overall. And if this is the amount of paracetamol you took, then it's more than 150 milligrams per kilogram. Okay, if that makes sense. I missed the answer to the insulin question 8. Oh yeah, go back to that. All the way back. Oh no, too far. On your got a bit overzealous in my clicking. Is after this one? After this one. There we go. So the answer to this was C. Oh, Katie's written a good explanation of mixed per kg for the person that wanted that question answering.
So yeah, did anyone have a question about this one, or was it just to have a quick look at the answer?
Just a quick look at the answers, I think. Would the evening/bedtime blood glucose level be considered too high here?
So let's have a quick look. So 8, 7.5 and 12. So one of the key things I mentioned in the question about adjusting people's basal insulin doses is to look for a trend. And so 8.5 and 7.5 is okay. It's like give them some slack. They're an inpatient and they're not very well, and so that might make them a bit hyperglycemic. And then they've got one random result of 12. So maybe just before this they had a jelly baby and their BMs are normally fine. So the most important thing to do is look for a trend. So in terms of the morning hypos, that's pretty consistent. 4.3 is still relatively close to having hypo, and the other two are definitely hypos. So the 12 at 10 p.m. I would disregard, because it kind of doesn't fit the trend of the normal BMs throughout the day and on the previous days. So I think that's fine. I wouldn't insulin because of that. Sorry.
If you're looking for a bit more information on insulin glucose, there's a good treatment summary under type 1 diabetes on the BNF. So if you want to get like the proper reference ranges for glucose, stuff like that. But yeah, I just sort of add weight to what Katie says, like look for a trend. Like a spurious blood glucose result isn't something to be changing your management over. So often the diabetes nurses use like days worth of results to work out what they're going to do next.
So yes, you can go back and review your answers on the PSA. I could when I did it anyway, and I don't imagine that's something that they would change. We'll try and send the slides over as soon as we can. Yeah, we know your exam's coming up very soon, so we'll try and send them ASAP.
Yes, I'll get on that. I will send the slides out ASAP, and that's just the feedback link while we answer the rest of the questions.
Oh, sorry, I think we've sent the feedback link to the hosts and panelists, but let me just send it.
No one to know you can find it. Sorry.
Can everyone see that now? Hopefully. Sorry.
I mean, I keep jinxing myself saying that I'm really good.
No, it's falling apart. I think it's got okay.
Is there another session? No, this is your lot. Your exam's on Friday, and you'll all be absolutely fine. You answered the questions really well. Where do you find blood glucose values in the BNF? Type 1 diabetes, that's the treatment summary. You can take a simple calculator in with you, yes. There's a lot of debate as to what this meant in our year. I think we all got a bit stressed about whether our calculator was simple or not. I think just one you can buy from W.H. Smith that doesn't have all the fancy bits on it. It just has like plus, minus, divide, etc. It's fine. Oh, I'm back. Yes, follow us on social media, obviously. Is it bad that I've only just started PSA revision? No, you've got 2 days. Well, I hope if you've been to these sessions, you'll be totally prepared, and that'll be your revision. Advice for fluid questions. You'll have heard people saying that fluids is an art, not a science, and I've found that to be so true. Just clinically, everyone has their own preference. Be careful about what their electrolytes are and how much glucose they're having, and whether you're prescribing maintenance or resuscitation, I think is the key here, because actually there are a lot of right answers. Yeah, the old-fashioned one is 1 salty, 2 sweet, which I think is quite a good one. So 1 bag of sodium chloride, 2 bags of like saline dex if you're struggling, if you're in doubt.
I'm just looking at this question. PCA overdose, how do we find the correct dose of sodium bicarb to prescribe? Am I right in thinking that you would only give sodium bicarb if they were having an arrhythmia? You wouldn't give it just generally for TCA overdose? I
thought you did give it generally for TCA overdose if they're unwell.
Entry, yes. I'm looking quickly on the BNF under sodium bicarb, and it doesn't give a dose, so I feel like it would be unlikely that they would ask you what dose to give if you can't access that information on the BNF.
Yeah, definitely.
That question will probably be kind of like one of the multiple choice ones, and they'd give you a dose in there rather than asking you to prescribe that.
Yeah.
But if it makes you feel better, then I'm sure somewhere on the internet, I'm sorry, you could find the answer for the exam, but I'm sorry that we can't be more help with that.
Do you give reference ratings in the PSA? Would you be expected to know these? If they're in the BNF, then you might be expected to know them, but if they aren't, then you won't be.
Somebody just said, why are you saying the PSA is on Friday?
Is it not? Oh, I thought it was.
I don't know when it is. Is it on Friday? I thought it was on Friday.
I think someone told me it's on Friday and I've just sort of run with that. Apologies, I've just stressed out 110 of you, and it's not actually on Friday. Yeah, I'm not setting it, so I don't know, but I've heard it's on Friday.
Sorry.
So sorry if it's not. If they're on Credible because it's sale on calculators, that's good to know. In prescribing section, would yeah, 15 minutes is fine for a bolus, 15 minutes or less. So yeah, if you write 15 minutes, it's fine, but not 20 minutes. I think it has to be less than 15.
Yeah, so if you're prescribing morphine as a breakthrough pain relief, you would prescribe that as immediate release because they've got pain now and you'd want to treat it immediately.
So fluids, really complex. What is the standard maintenance fluids? 0.9% or 0.45%. I think it's very trust specific. I have never seen 0.45% used. I'm not sure if you have, Katie. We use either 0.9% or 0.18% with 4% dex. I cannot see you getting marked down for fluids if you prescribe a sensible maintenance fluid, if that is what the question is asking. Just make sure that if you're not adding potassium into a potassium deplete patient, you might lose a mark. Or if you're not giving any glucose, you might lose the mark. So just go think about, 1 mil, I think it's 1 millimole per kilogram per day of sodium, potassium, and 50 grams of glucose. And then I think it's about 30 mils of fluid, isn't it, per kilogram per day. So just like keep those values in your head when you're prescribing to make sure you're hitting all of it, and you'll be fine.
So if you want us to go back to different slides, I think it's probably better if you just fill out the feedback form and then you can do all of that in your own time in terms of like browsing the slides, if that's okay.
And there's a couple of questions on the ECG, Katie, if you feel up to.
Okay. Yeah, that's fine. No, we'll have a go.
Here it is.
Okay, so sorry if it's a bit small for you guys, but if you can kind of, I don't know if you can zoom in on your laptops, but if you have a look, then you can see that this ECG is showing kind of a P wave and then a QRS, and then a P wave and then nothing, and then a P wave and then a QRS, and then a T wave, then a P wave, then nothing. So they're having one P wave, a missed beat, and then a P wave, a conducted beat, then a P wave, then a missed beat. So it's a 2-to-1 block. So you've got 2 P waves for every QRS. So in terms of the different types of heart block, 1st degree heart block, you never drop a beat. You just have a long PR interval. 2nd degree heart block is when you start dropping beats. So you get a gradually increasingly prolonged PR interval, and then you drop one in Wenckebach's, which is Mobitz type 1. And then Mobitz type 2 is when the PR interval is fixed, but you're still dropping beats. So the Ps come regularly, the P waves come regularly, but every now and then, and sometimes at quite like reliably kind of reliable intervals. So you might have 3 P waves and 1 QRS, and that would be a 3-to-1 block, or 4 P waves and 1 QRS, and that would be a 4-to-1 block. This ECG is a 2-to-1 block. So when you get the slides, you'll be able to see it clearer, but essentially it just has a P wave, then no QRS. I don't know if that's helpful at all. But that's second degree heart block. And then third degree heart block is literally, there's no association between when the P waves are coming and when the QRS is coming. So the P waves might come at reliable intervals, but the QRSs are just dotted around and there's literally no sense that you can make of it. And those patients might be like really bradycardic. And if you've got kind of second degree heart block or third degree heart block, then you need a pacemaker, because you could arrest, basically. But you can see on this ECG, this patient doesn't have a pacemaker because there's no pacing spikes. So they're normally like very small straight lines just before each QRS to make sure that they're having a ventricular systole regularly. Does that help at all? I'm sorry, I feel like I've just rambled for a bit there.
I think that's great. There's a couple who wanted to see the paracetamol stem again, so I'll just go back to that question.
Okay.
People are loving your table. I'm also loving your table.
Thanks.
So that is the paracetamol question. Yeah.
Cool. Hopefully that's like most of your burning questions answered. If you've got anything else, we'll give you a few seconds to stick it in the chat. Otherwise, we'll call it there.
There's a question all the way up at the top about the exacerbation of COPD versus HAP. I think you answered that really well. Yeah. Someone's been in hospital for a long time, it's more likely to be a HAP than an exacerbation, just because of the stem, because of their circumstances. That's what they're leading you towards. Could you get the feedback link again? Yes, it is in the chat. The right chat now. Sorry, everyone. I'll resend it in case it's gone.
In terms of exacerbation, it's entirely possible that the HAP has exacerbated her COPD. In fact, I would expect a HAP to exacerbate someone's COPD. So she does have an exacerbation of COPD, but because she has a HAP. So the definitive treatment for that would be to give her IV TAS rather than oral doxy and pred. You could give her IV TAS and pred, but oral doxycycline wouldn't treat the bug that's causing the pneumonia.
Yeah, I think also just like think about what's in the stem of the question. Like every sentence in that stem is there for a reason. It's sort of telling you what they want you to think. Yeah, a COPD exacerbation, you're more likely to to be a stem of a patient with COPD coming in acutely and well, I think, just because otherwise, if they're in hospital, it is leading you towards a HAP. Cool.
Well done, everyone.
I can't really see any questions we've not answered. Apparently the PSA is at different times, different medical schools. So if you're that person who's not started revising yet, maybe your exam's in March and you're absolutely fine. You're still absolutely fine. There's not a lot to learn. You've got the BNF with you. Cool. Thanks everyone for coming. Hope you enjoyed it. I'll send the recording out and the slides.
Hope it goes well.
Good luck.
Bye.